Well, welcome everyone. This is a session on commissioning and primary healthcare. Is it a path for Australia? My name is Ellen McIntyre. I'm the Director of the Primary Healthcare Research and Information Service, and I'd like to welcome three of my guests here to this conversation. So we have Judith Smith, who's the Director of Policy at the Nuffield Trust. We also have Associate Professor Helen Dickinson from the School of Government at the University of Melbourne. And finally, and last but not least, Mark Booth from the Department of Health, who is the First Assistant Secretary in the Division of Primary and Mental Health. So welcome. So let's get started straight away. Now, Judith, can I start with you? You have experience of a number of health systems, including the NHS in New Zealand and some experience here in Australia. So can you give us a bit of a broad brush about what does commissioning mean, and particularly in primary health care? Because it's a new term to some people, but I noticed in some of the papers you've written that you call it strategic planning and purchasing. So perhaps elaborate a bit more on that.
Yes, I mean, commissioning is a term that in health policy is peculiarly English, really. I mean, it doesn't even travel to Scotland, Wales and Northern Ireland, let alone further internationally. And you're quite right that in the broader international context, I think what is thought of often as commissioning is indeed more commonly referred to as strategic purchasing, or perhaps one I like in particular is what the New Zealanders call planning and funding. But I think most profoundly what commissioning is concerned with is about how we make the really difficult decisions about how we allocate scarce resource to meet the needs of a particular local or national population.
So it sounds a very logical way of doing things, but are there some issues around commissioning that we need to consider, some warnings and challenges?
Well, it's a difficult concept and an even more difficult activity for policymakers, health funders and planners, and indeed clinicians and others to actually undertake. And I think there have been many attempts in different health systems to use contracts or purchasing as a means of trying to be more focused, perhaps disciplined, about this relationship between resources and what the funders are actually wanting in return for that resource. But some very helpful work that was done in the 1990s about this was by John Evidencebased, who's a Scandinavian academic. And it was he who really coined the term commissioning for healthcare. And what he was really driving at was to say that commissioning is something extra beyond the kind of transactional activity of a contract or indeed of purchasing. His work, and he developed what's called the cycle of commissioning, where you assess needs, you specify services, go out and contract for them, then review, then in a sense start all over again. But he said that the intent behind that is about trying to bring about something more, some change, some, if you like, some improvement in people's health, some different form of service provision. So there's a sense of something dynamic, something actually really quite creative and constructive. So I say Evidencebast's work from the 90s, I think, is still quite influential in this area.
So commissioning can happen at different levels, and so can you perhaps elaborate or give us a few ideas as to what are some of the key issues about commissioning at a national level, and then how does that operate at a local level?
Yes, you're absolutely right that commissioning occurs at many different levels, and indeed in work that I and other colleagues in the UK were involved in about 10 years ago, we talked about the continuum of commissioning, and that can be right through from at the national level. You'll have perhaps arrangements for purchasing highly specialised services that need to be planned and funded at that national level, through regional commissioning and purchasing, through more local purchasing, perhaps for a population that's often of about perhaps between 50 and 250,000, right down to individual purchasing, because many health systems now are experimenting with people having personal budgets to perhaps buy their care if they've got disabilities or long-term conditions. So that's a really important point, that commissioning happens across the spectrum.
Good, thanks. So Helen, do you want to add any more to that, or can I ask you more about what are the capacities required for a good, for an organisation to do good commissioning?
In some ways, that's quite a difficult question to answer, in the sense that, as Judith mentioned, commissioning is a really complex process, and it's one that's quite difficult to get right, and certainly in England it's one that various different iterations of organisations at a number of levels, as you say, have struggled with. And if you look to the academic literature, there are a few examples of really high-performing commissioning organisations. So to some extent, that's a challenging question. But I think one of the reasons why there aren't that number of those studies out there that demonstrate kind of clearly high performance in this area is the complexity and the difficulty of the task. Now, what that suggests also is that this isn't just a technical exercise. So there are technical aspects to commissioning, and often people get hung up around, do we have the right data to be able to talk about kind of existing services and needs? One of the huge challenges in a UK context and other places has been about actually just knowing what we currently deliver and what that costs us to do it on an individual delivery basis. And there are real challenges around that, but probably the more difficult bits around commissioning are those that involve what you might talk about in terms of softer skills. So one of the crucial things in making commissioning work is being able to engage across a broad spectrum. So that involves engaging with your clinicians within a system, and particularly doctors play a strong role in there, and engaging with communities as well. If we don't engage effectively with communities in a discussion about what we want in terms of health services, what the offer should be, then it's very difficult to be able to commission effectively. And I guess the final issue that for me that is really important in terms of that is having legitimacy as an organisation. So in an English context, one of the roles of commissioners in primary care was about trying to shape and change the ways that services are delivered through secondary care. So thinking about the most appropriate places for services to be delivered, and that will involve a degree of reconfiguration. But there's a huge challenge to be able to drive that from the commissioner's end if you don't have legitimacy in the eyes of your local population or with the eyes of the clinicians or other people who work within those systems. So the key for me is that it's complex. There are a range of different skills that are required, and unfortunately it isn't something that we can just kind of get right. There isn't a textbook with a set of skills or competencies, and provided we just have those, then we'll be able to deliver commissioning. As Judith said, it's a difficult and complex role around deciding who should get what in terms of resources. There are huge ethical and moral implications in terms of the number of the debates. It's highly political. And as such, there isn't an easy fix in terms of that, and just focusing on the technical, data-driven aspects of that won't deliver it for you.
So it's also a matter of economics, isn't it? I mean, it's not as if we've got an unlimited bucket of money to do commissioning, particularly in primary health care. So any comments about that? How do we make sure that we still have an effective health system with commissioning that provides a very effective outcome, but with less dollars?
You're right that economics is important there, but I mean, I spent quite a while doing research actually funded by the Nuffield Trust into priority setting in the English NHS, and a number of times we went around to talk to people and they would say to us, if only we have a health economist, we'd be able to make all this work. And, you know, whilst I have a great degree of sympathy for that as a kind of a comment, and there probably would be some space for those sorts of skills within an organisation, that actually isn't what's going to, you know, deliver the step change in this sort of thing. So it's, as you say, it's moving to an explicit decision in a number of, you know, in many healthcare organisations, how we decide on resource allocation at the moment is in more of an implicit mode, or we switch to alternatives to explicit priority setting, like, you know, waiting lists or delaying or implicit rationing through the activities of clinicians within that system. Moving to an explicit mode of talking about how you're setting resources in the system is incredibly complex, and it's incredibly difficult because you bring all those different competing claims to the surface. You're encouraging them rather than trying to push them down. As you say, that's a huge challenge, and there is a role for economics within that context to think about, well, how best can we get good technical and allocative efficiency within that system. But if you do that without having that debate around, well, you know, what principles should underpin resource allocation, who should we be giving these scarce resources to, what services don't fit within this offer, how would we like to see services be offered, what would our preference be around that? It'd be very difficult to deliver that without those engagement aspects.
So it really does come back to people of from all sorts of areas coming together. So maybe, Mark, I can get you now to give us a bit of a perspective of Australia and whether there is any commissioning happening here, as I'm sure there is, but can you perhaps elaborate a bit more?
I think just picking up on some of the points my colleagues have made, I think we have a system in Australia of primary health organisations known as Medicare locals. And some of the aspects of commissioning that have just been talked about, I think, are present in a number of those primary health organisations. So the cycle that was just being talked about in terms of looking at health needs assessment, looking at taking that health needs assessment to really look at what a population does and the kind of services that a population requires, and linking in with local communities, local clinicians, and then taking that information, putting it into contracts, and then going through that priority setting process is one that does exist. And I think if you look at where Australia has tried to get to over the past few years, really, I think we've tried to move in that direction. Having said that, I think it's also fair to say that there has been variable experience in terms of how well we've actually done that over the past few years. You know, some areas have done it extremely well. There were some areas that had been doing some Medicare locals, for example, that had been established and moved forward from divisions of general practice before them, who've been doing this for many, many years. And they take this forward and have been doing it extremely well. Some of the Medicare locals, which were only established a couple of years ago, still finding their feet, still trying to actually get across this, and, you know, how do they actually do that? I think that's been a particular issue that we've faced. I'd also pick up on the point that was made immediately before around about the resources and the expertise that's actually needed to do this. I think this is an issue that many countries have faced. I think it was faced in the UK. I think it was certainly faced in New Zealand, and very, very, very aware of it here, that you actually need that expertise to be able to do this very effectively. You do need the epidemiologists, you do need the population health planners, you do need the health economists, you do need that range of expertise to actually come forward and do that. And we don't have an abundance of epidemiologists, health planners, health economists within Australia or within New Zealand or within the UK to actually do this and make this work. So it is a complex area. But I do think the aspects of it that we've had are currently present within the system within Australia. I think the challenge that we face is this variability across the country of how well it's done and how well it's moved. I think we face continuing challenges within Australia around the imbalance, if I can call it, the power imbalance between primary care and secondary care, and how well that works, and how a primary health organisation can effectively be of a size to adequately impact upon, for example, emergency department admissions, secondary care admissions, how that can be effectively done by a primary health organisation, which is very small in comparison to a typical tertiary secondary care institution, and how you actually do that. I think that's a challenge that we've got going forward, as well as the general challenges around resource allocation and trying to reduce the cost curve going forward.
But it's more than just looking at health, isn't it? It's looking at all the other features that impact on health. So, and as we are aware, Australia has got a unique geography in that we have a lot of rural remote areas. But then Australia also has its own unique resilience. Can you elaborate a bit on that, on how we are doing things in Australia that would really enhance primary healthcare right across Australia?
I think the point that you make around the rural and remote is very well made. I think it's a particularly unique, well, not unique, I think a small number of other countries do face it, but we certainly do have areas of the country where there is a real lack of primary care services, where we have, for example, no privately practicing GPs, and the challenge then is how do you actually make the system work as a system in an area where there is really, to use the term, there is market failure, because there is no market and there are no other people to actually do it. And what we are tending to see a movement towards now are states and territories and Commonwealth working together much more closely to actually look at how, for a population, you would most effectively use the resources that are going in there. On the other side of things, I think we are really transforming and doing some very exciting work around telehealth, around traditional strengths that we've had around the use of aeromedical services, visiting practitioners. We've had a very well established rural health outreach service that's been operating for many years, and pulling that in to the overall system view, I think, is something that we've done extremely well. And that service also, of course, links in with specialists within secondary care to try and get that secondary care outreach service working well in remote areas.
Thanks. And can I come back to you, Judith? You were talking about, and I think Helen, you mentioned too, that we don't always have the evidence to show if something is working, particularly around commissioning. What do we need to do about that?
I think, well, there's whether we're considering the evidence in terms of the evidence of particular services we want to commission. And that's clearly an important part of it, as Mark was talking about, in terms of the skills we need. Because I think one of the intents behind commissioning is that the funding of services will be more evidence-based. Now, that's difficult to do, but I think that's one of the main reasons why people try to have what we call a commissioning approach, to have something a bit more robust that's taking epidemiological or indeed other evidence, which might be the views of local people about the services they want and how they want them provided, or indeed of local clinicians and how they want to work. But it's taking those and trying to line them up with the available resources, and indeed, back to the point I was making about John Everett's work, to actually change the way services are provided locally. When we then shift, though, to think about the evidence in relation to the activity of commissioning itself, one has to be honest and say it's quite equivocal. I mean, there's have been a number of quite big studies in just the last 3 to 5 years in the UK looking at the practice of commissioning. And there was one that I led at the Nuffield Trust, but funded by our National Institute of Health Research, really trying to understand the activity of commissioning, the nitty-gritty of commissioning we talked about. And our main conclusion from that work was, we talked about the labour of commissioning, the huge amount of work that goes into that. And I have to be honest in saying that we were unconvinced about sometimes the extent of labour, the activity, the effort, the resource that goes into the transaction of commissioning, compared with the often relatively marginal gains in services that seem to be achieved as a result. So I guess the conclusion from that would be there's a need for some real focused thinking about when it is you put in this kind of huge amount of effort. And that my own view on that would be, if you've got a really, in a sense, difficult nut to crack in terms of services for a particular community where you're struggling to provide viable, high-quality services, or there are big questions about, for example, how, could be about services for older people for a particular community, is to focus the attention, I think, where it's most needed. But I say there's a big caution from that work, and also from work that Helen has led around what's often called joint commissioning, where you're trying to do this activity alongside perhaps housing and welfare and other services provided by local government or other agencies. Again, there have been questions in that work about the risk, often on the part of health managers, sometimes clinicians as well, to almost spend so much time on what's often called the relational side of commissioning, bringing people together, reviewing services, consulting, lots of service specification work. There's often I think something about healthcare professionals and managers, they they warm to that kind of engagement work, but they often find it much tougher to do the difficult bit of commissioning, which is actually to say, we're going to stop doing that. We have to stop doing that if we're going to do this new activity or service, or we're going to use the contract to actually say, no, it's not good enough what's being provided at the moment, or we're going to be much more strategic and focused in how we review these services. So going back to John Urquhart's cycle of commissioning, our work trying to build evidence in this area is that there's a lot more activity on the relational, the needs assessment, the planning, the service specification. People find it much tougher to do the hard decision making and indeed the critical review of services.
It is interesting, though, that observation as well in terms of what's going to deliver over the longer term, because as you say, you know, often those difficult decisions are even more difficult if you don't have those relational aspects in place. And so one of the interesting questions is for the research that you and colleagues did, Judith, is if you go back in a few years, the degree to which, you know, that original groundwork will have led the way for being able to take difficult decisions in the future. One of the challenges in an English context is unfortunately the kind of context and the framework and the machinery around commissioning has never stayed sufficiently stable for us to be able to talk about those sorts of issues. So in the study that we did around joint commissioning, which Judith mentioned earlier, that was again, you know, if we'd done this study, it was again facing another change. And one of the things we highlighted there is, you know, where people had been quite successful and typically they had worked around a particular area. So it was about learning disability services, or it was about services for older people where there were significant difficulties and they had a good sense of what they were trying to achieve in terms of commissioning. So they had an aim and people could buy into that. Where there was that, it tended to be more effective. One of the challenges is now a lot of those organisations who had made headway there have kind of shuffled round and don't exist in the same way anymore. So that doesn't mean those relationships aren't there in the system and they maybe you've reconfigured differently, but some of them will have been pulled apart again. And I guess for me, one of the interesting things about Australia when we talk about the challenges that are present in rural and remote communities, but the other thing to remember there is you tend to have a slightly more stable population and you have a group of individuals when they're there who are invested in that area, and you can't underestimate what that gives you in terms of pulling together with a particular aim in terms of commissioning.
So Mark, how can these learnings be applied to Australia?
Yeah, look, I think the general comments that have just been made around the disinvestment and the difficulty of decommissioning and the difficulty of making those hard decisions, it's not unique to Australia. I think it's unique across the world as to how you do make those decisions. I do think when you're looking at a healthcare system, you need to consider economic cycles, and to a degree when money is tight and you are very much constrained by what you do, you are by necessity forced into a position where you do have to look at the cost effectiveness of different services and what you do provide. And you do need to really make a conscious decision about whether you're getting the bang for your buck for that particular service than you are from another particular service. So I think that drives that kind of conversation and helps that conversation. But I think the other thing that it does, to just bring it back to where we were before, is that if you look at a system-wide view of things, we do know that one of the key cost drivers is around hospital activity and continuing high costs of hospital treatment and pharmaceutical treatment and medicalisation and those kinds of things. And we kind of, I guess there's a kind of a belief that investment in primary care and appropriate primary care processes will alleviate some of the cost pressures on hospitals by trying to prevent admissions to hospitals and that kind of thing. So you can look at the cost curve in that sense as well as just the individual services that are being done, try and look at it in more of a system perspective. But I think ultimately that probably involves doing some kind of resource reallocation between the different sectors, which is difficult in the Australian system, where we have a federal system.
Yeah, reallocation is something that there's an ongoing thing, but if it's got the evidence to support your decision making, then surely that's much better than just because you have to change.
Absolutely, and you know, the use of that evidence is what we do use and should be using. And I know there are examples from overseas where specific hospitals, specific areas have contracted with primary health organisations and providers to actually give them targets in terms of bed day reductions, for example, in secondary care, to actually then reallocate those resources and say, if you do achieve those bed day reductions, then you know, that's how we should move forward. So I think those kind of models are moving.
Yeah, Judith.
There's just building on what Mark was just saying there, I've been really interested recently in work that's been going on in New Zealand in Counties Manukau District Health Board in South Auckland, because what they've been doing, I mean, New Zealand benefits from quite an integrated health system in terms of the planning and funding body. The District Health Board also runs hospital services and indeed contracts with primary care. And in Counties Manukau, they've been trying to use that sort of degree of system integration to do exactly what Mark was saying. I recall the target they'd set was a reduction of 20,000 bed days, I think, over a year. But in doing that work, engaging clinicians from secondary care and indeed using their primary health organisations locally, so their networks of general practice and other health providers, to think really quite differently about how to put in place preventative or supportive services that could either keep people out of hospital or enable them to be discharged earlier. And the reason I mention that point is that quite a lot of the thinking I've been coming across in Europe and to some extent with the accountable care organisations work in the United States and what I just mentioned in New Zealand is people trying to think beyond the idea of commissioning as just there are some who pay here and some who provide there, and the payers will tell the providers what to do. I'm exaggerating to prove the point. But people starting to say, actually, we need some different ways in which the providers, and ideally the secondary care and primary care providers together, are somehow incentivised and indeed held to account for delivering some health gain or benefit, or that could be expressed in terms of reduced bed days, but it could be also in terms of improved health outcomes together. So it's more of a shared enterprise. So, and I think there's some interesting early evidence emerging from the United States about the accountable care organisations, which are absolutely, as the name suggests, trying to deliver some health gain for some improved use of financial resource, which of course is a huge issue for them in the United States.
Well, look, I think we're just about ready to wrap up, but while you're thinking of your last points, it seems to me that a lot of this is based on people engaging with others to really sit down around the table and discuss what needs to be done. So in terms of, well, we've looked at the health systems in specifically in the UK, the NHS, the New Zealand and Australia. What are some of the pieces, what advice would you give to Australia in terms of commissioning in primary healthcare?
I think, first of all, to be clear about, are you talking about commissioning of primary healthcare, so using commissioning to actually improve, develop and extend primary healthcare, or are you thinking about the role of primary healthcare in commissioning other services? And they're two very important activities, both of which are present in different health systems. But sticking with primary healthcare, for me, at the moment, the most interesting thing I'm observing internationally, and I'm thinking here of countries like the Netherlands, the UK, Canada, New Zealand very strongly, Australia also, is the innovation I'm seeing on the provider side in primary care. I'm seeing primary care practitioners increasingly recognising the need to work at greater scale, and that doesn't mean merging organisations necessarily, often working in much stronger networks, as in the primary healthcare networks in New Zealand that have grown out of their Independent Practice Association movement. But again, you're seeing those very strong primary care networks, as I mentioned, in the Netherlands. They're emerging quite rapidly in England at the moment. And I think what they're saying to me is that actually primary care has recognised that it has to be, in a sense, strengthened and built up if it's going to be able to provide this stronger out-of-hospital care we're always talking about. So yes, this is about commissioning, but actually primary care itself needs support, and I think needs to be commissioned itself in a different way if we're going to meet the challenges ahead.
Okay, thank you, Judith. Helen?
Yeah, I mean, I'd echo Judith's comments there, and one thing that's really important for me, I find it's very interesting that, I mean, this isn't just in terms of the Australian healthcare, but more broadly in terms of Australian public services. When I go and speak to people, they're very interested in what's happening, what's being developed in other countries, and I think, you know, that's right, and there are lessons and there are evidence that we can draw on other places. But I mean, my experience of Australian public services is there are some really great people out there, and actually some of the best public services in the world out there. And actually, whilst taking some lessons from other places is a helpful thing to do, a bit more of kind of looking inside and saying, well, you know, are we sure we've got the right sets of skills there? Have we got a clear set of what we're trying to achieve in terms of our commissioning aims, if that's what you want to call it, or in terms of your strategic planning? The kind of the death knell in this area would be to politically say everywhere needs to do commissioning. I think it confuses the picture, and it becomes a kind of the means becomes the end itself. And almost that's one of the challenges that we encountered in England, was that because every organisation had commissioning in its title, because lots of individuals had commissioning in their job titles, it was felt as though it was done already. So I think you're right, there's a lot of good evidence out there and we should look to that, but there's a lot of good practice in this country as well, and learning from that and sharing some of that learning and thinking about how we distribute that more broadly, I think is a really helpful lesson.
Thanks, Helen. So Mark, is commissioning and primary healthcare, is it the path for Australia?
I think certainly a lot of the aspects of commissioning that we have been talking about are the path. I mean, certainly a lot of the areas we've been talking about in terms of getting local involvement within decision making, getting clinical involvement and getting clinicians leading a lot of the process, ensuring that health services are appropriate for the population that they serve, and making sure that professionals have the tools to be able to assess that they're working effectively and efficiently for that population is absolutely the way to go. In terms of whether we've got there yet, I think that's another question. I think it's an evolving path, and I think we have to see in the future where things can go to there. But there's a lot of lessons that we can learn. I've often observed one of the things about Australia is that because of its federated structure and the way that we actually work here, things progress a bit more slowly than they necessarily do in more unified systems, and it's often more easier to actually take the lessons and the learnings and the evidence and then do a bit more of a considered response and move forward. We don't tend to chop and change as much as, for example, in some other countries. So I think the thing to do is to take those learnings and then see where we can move to and pick the best, really.
Good. Well, thank you very much, Mark, Helen and Judith. And thanks everyone for joining us. And as you would have heard, we mentioned a number of publications that are available in the public, but we'll make it easy for you and add them to our website, and also as a slide at the end of this video clip. So thank you, and we'll see you next time.